Any other questions? Yeah, if not, we'll start with the next lecture, which is on adjuvants in PCOS. It's by Dr. Chaitanya Shembekar, who's the clinical director of the Omega Hospitals Private Limited, Nagpur. He's been the past president of Nagpur OBGYN Society, chairman of the Infertility Committee of MOGS, librarian of Maharashtra ISAR, member Fertility Committee of FOXY. He is the recipient of Kamini Rao Yuva FOXY Oration Award and Dr. Kumud Tamaskar Oration Award in the year 2021. He has several publications to his credit, both in national and international journals, and has also contributed several chapters to the textbooks. Over to you.
Thank you, Madhuryan. The topic for the discussion is adjuvants in PCOS, and I bring greetings from Nagpur OBGYN Society, IMOGS, where I am working as a chairperson, and Maharashtra ISAR, and from Omega Hospitals, Nagpur. My special thanks to Dr. Lakshmi Shrikande, Dr. Madhuri Patil, Madam, Dr. Parag Biniwal, and Dr. Mandakini Meg for giving me this opportunity. I would like to first discuss something about PCOS so that you understand in a better way why and how the PCOS requires adjuvants. So for that, we have to go to the basic pathophysiology and understanding of PCOS. So we all know that there is 5 to 10% incidence of PCOS, and 75% of anovulation is because of PCOS. That means there is one thing which is very clear, that PCOS means anovulation and anovulation means PCOS. And this is how the polycystic ovaries look like. You all know that there are multiple follicles, and you have to think of PCOS right from the adolescence. So ये लंबी कहानी है और ये कहानी शुरू होती है adolescence से. And the mantra is to catch them young. Now we should know basically that what is the meaning of PCOS, and you should know when to label any girl as a case of PCOS. For that, try to understand one basic point, that is, if you have irregular cycles in the first year after menarche, it is considered as normal. So do not label a patient as PCOS if there are irregular cycles in the first year. After 1 year, if there is any one cycle which is more than 90 days, it is considered as irregular. From 1 year to 3 years, if the cycle is less than 21 days and more than 45 days, it is considered as abnormal. After 3 years, if the cycle length is less than 21 days or more than 35 days, it is considered as irregular. And if there is no menses up to 15 years of age or after 3 years of thalarche, it is considered as abnormal or primary amenorrhea. So when you know about this basics about the irregular cycles, then you will realize that you should not have any hurry to label a case as a case of PCOS. In fact, if a young girl comes to you with multicystic ovaries, you should label it as multicystic ovaries and re-evaluate or reassess the patient after 7 to 8 years of menarche. That means at the age of 20 to 21 years, you have to reassess this girl and see if the patient has got PCO before starting OC pills, if there is a persistent feature of PCOS even at the age of 20 years, or if there is obesity, then you should label it as a case of PCOS. So you have to have these things clear in your mind, and this is what the guidelines say, that for adolescents who have features of PCOS but do not meet the diagnostic criteria, you should call it as an increased risk of PCOS, and then after 8 years post-menarche, you should reconsider, reassess, re-evaluate, and then label her as a PCOS patient. We know that 2018 guidelines for ASHRAE has said that Rotterdam criteria are endorsed as the criteria for the diagnosis of PCOS. But there are many groups working on PCO, and we should try to understand what the various groups have to say. If you just look at the NIH classification, NIH says 1990, it's an old classification which says that there should be a hyperandrogenemia and oligo or anovulation. Then ASHRAE classification, we know the 2 out of 3 criteria: hyperandrogenism, ovarian dysfunction, and polycystic ovarian morphology. There is something called as androgen excess PCOS society, which obviously says that there has to be hyperandrogenism to label a case as PCOS. And then came the extension of NIH criteria, that is an extension of Rotterdam criteria, that this came into 2012, and this criteria is important for us because they have not only considered Rotterdam criteria, but they have added phenotypes into this Rotterdam criteria. And these phenotypes are important for us because once you know about the phenotypes, then you will be able to diagnose a case in a better way. Now let us see how the phenotypes goes. There is something called as phenotype A, which is a very classical case where there is a hyperandrogenism, ovarian deficiency, and polycystic ovarian morphology. Then there is phenotype B, where USG is normal, but other features of PCOS are there. Then there is phenotype C, where the patients are ovulating, but they have PCO on morphology. And then there is a phenotype D, which is a lean and thin PCO, where the features are mild. Features of PCOS are there, but they're mild PCO features. So these are the 4 phenotypes. And when you know these phenotypes, then you can actually make it a habit to, try to fit your patient into one of the 4 categories or phenotypes, and then you know how to manage these patients. Why I'm telling you all these things is because this is something which you should know before you start discussing about adjuvants. One important thing which we all should know is something about lean PCO and obese PCO. What is the difference between lean and obese PCO? Whenever we think of PCO, one typical picture comes in our mind: a stocky build, obese patient with hirsutism, with acne, with acanthosis nigricans, and all classical features, which is a flash diagnosis. The patient enters into your outpatient, and you know that your office, she comes and you know that she is a case of PCO. This is a flash diagnosis. But there is something called as lean PCO as well. And this lean PCO, they belong to 20 to 50% of PCO. So PCO are of 2 categories, and you should try to understand the difference between the two. LH-FSH ratio is something which is nowadays outdated. We no more talk about LH-FSH ratio in the diagnosis of PCOS, but there is high LH level which is seen in lean PCO. Second is androgen excess. It is more in obese PCO as compared to lean PCO. Then hyperinsulinemia. It is more in obese PCO, but it is there and still there in lean PCO. Insulin resistance is more in obese PCO, but it is still there in lean PCO. Androgen levels are high in both, but more in obese PCO. Hypertension, impaired glucose tolerance, diabetes mellitus, and endometrial hyperplasia. All these classical features and the long-term effects of PCOS, which are seen, are more commonly seen in obese. So in short, obese PCO, there is an overt PCO picture. All the complications are more commonly seen, but all these things are still there in lean PCO. And why I'm telling you this is because there is a relation of this with the adjuvants, which we'll be discussing in after some time from now. There is a concept or an idea which people have in mind that metformin is only meant for obese PCO. It is not so. Metformin will work even in lean PCO, and therefore you should remember one thing, that metformin can be given in lean PCO as well, because all these features are seen in lean PCO, but they are to some extent less as compared to the obese PCO. Now, as I told you, there is something called as phenotypes. There is something called as ethnicity, and ethnicity has also got a role to play as far as the PCOS is concerned. And these are the guidelines which say that you can actually come to know about the phenotypes from the ethnicity. There's an ethnic variation in the presentation and phenotypes. Relatively mild phenotypes seen in Caucasians, high BMI seen in North Americans and Australians, severe hirsutism seen in Middle Eastern and Mediterranean women, increased central adiposity, insulin resistance, diabetes, metabolic risk factors, and acanthosis nigricans. All the classical features of PCOS are seen in Southeast Asia. That means in Indians and indigenous Australians, you will get these features of PCOS. Low BMI in East Asians, like your Japanese, they have low BMI and mild hirsutism, while high BMI and high metabolic features in Africans. So you can come to know about the phenotypes from the ethnicity as well. Now, when you talk about the diagnosis of PCO, you have 3 things in mind: clinical hyperandrogenism, biochemical hyperandrogenism, and ultrasound. Clinical hyperandrogenism is where there is a hirsutism. Patient has got acne, patient has got alopecia and hirsutism. And there are modified Farman-Galvez scales for hirsutism. We did not discuss this in details because this is not a topic for discussion. Ludwig score for alopecia, and there is no system for acne, but acanthosis nigricans is something which is seen in 50% of obese PCO. Now, whenever we are discussing this clinical part of hyperandrogenism, you have to think of the psychological and psychosocial impact of this on the patients. When a young girl comes to you, she is, depressed because she has got hirsutism, she is obese, she has negative body image, and therefore she is not happy with her body. constitution, and that has its impact, and that is a psychological impact. So you have to take care of that psychological impact as well. So TLC or tender living care is something which you should also keep in mind. Now comes this biochemical hyperandrogenism. Now, what are the biochemical features of hyperandrogenism? Testosterone is raised, free testosterone, free androgen index, DHEAS and androstenedione are raised. DHEAS and androstenedione should be done if testosterone is not elevated. Now, testosterone, if it is very high, that is more than 200, then you should think of other causes of high testosterone levels also. Then you have to think of FAI, that is free androgen index, because it is the most sensitive marker for the diagnosis of PCOS. And all these features are important, and all these tests should be done to diagnose clinic biochemical hyperandrogenism. These tests are different from the test of infertility. Mind well, infertility tests are FSH, LH, prolactin, a free T4 TSH, and AMH. So these are the tests for fertility. But apart from this, you have to find out the extent of hyperandrogenism. Then you have to do all these tests along with this. And then there is something called as impaired glucose tolerance. And this impaired glucose tolerance is, as I've told you, that Asians are more prone for diabetes. Fivefold increase in the possibility of impaired GTD is seen in Asians. There is an association with obesity. And what are the investigations you will do? You should do OGTT and HbA1c. Remember, friends, fasting insulin is not included in the armamentarium, and it is not to be done as an investigation for PCOS. As we do not do LH-FS ratio nowadays, we should not do fasting insulin as well. So OGTT should be done in all the patients if the BMI is high, especially in Asians if it is more than 23. And you should always plan and start treatment before conception by doing OGTT if you are dealing with a case of PCOS. And along with OGTT comes the lipid profile. So you should do lipid profile as well, because lipid profile and OGTT, they go together, especially in Asians. The way to get started is to quit talking and begin doing. And that is what we are going to do now. We will start discussing about the adjuvants. I will, in short, discuss a case of Yasmin so that you have an idea about how to go ahead with the adjuvants. Yasmin is a young girl. She is only 25 years. She is married since only 3 months. But her BMI is 30. Her waist hip ratio is 1.2. She is a classical phenotype 1. Phenotype A patient. As we have discussed phenotypes, you will understand and realize that this patient belongs to phenotype A. Or she is on Yasmin, that is OC pill, since last 2 years because she's having irregular cycles, and now she is eager to conceive. Why she is eager to conceive? Because she knows that there is a problem. That's why she has come early to you. Just after 3 months of marriage, she has come to you because she knows that there is a problem. So what should be your approach? How do you start? One thing is, as I told you, stop body shaming, because this is something which they have this problem of, negative body image, and therefore you should take care of this also. So lifestyle, emotional aspects, body image, all these things you should take care of in the case of Yasmin. And then you should actually stop OC pills. Why? Because it is said that when the patient is on OC pills, you will not get proper investigations. So to get proper reports, first thing you have to do is wait for 3 months and then do investigations after stopping OC pills. So that time you can utilize in psychological counseling, then physical exercise, and then weight reduction, and then you can counsel the patient, and after that you can do the investigations. So that is what guidelines also say. Now these investigations were done some 4 years back, and here they have found that there was an androgen excess. And now, as you know that she is a case of PCO with obesity, you will do her OGTT, right? You can do HbA1c also, lipid profile also. You will not do her fasting insulin, and you will do investigations like prolactin, free T4 TSH, FSH, and LH. You can do now because she has stopped OC pills. When the patient is on OC pills, you cannot do FSH and LH because there is an intercycle and intracycle variability, and it has got an impact on the drugs which she is taking. So if the patient is on OC pills, FSH and LH should not be done. So FSH and LH will be done 3 years after stopping OC pills. But there is one investigation which can be done anytime, and that is AMH. AMH is a wonderful investigation. Why? Because you can do it at any time. And I cannot imagine life without AMH. So look at the guidelines, 2018 guidelines, they have said that AMH is the future, but they have also given a word of caution. They have said that people have started doing it, but there is an emerging evidence that it is good, but the standardization is the problem, and therefore it should not be used now. But I agree to disagree with these guidelines because now we have already started using AMH as a very important marker for the investigations of PCOS and it is giving good results. और एक साल बाद देखिए क्या हुआ जब 2018 में हमको पता चला कि AMH नहीं करना चाहिए या करना भी है तो be very careful because there is a problem with the reporting. After 1 year, there is a strong evidence. 2019 ovarian stimulation guidelines clearly mention that AMH and AFC are the two investigations which alone can help you in detecting the ovarian reserve. So this is a strong recommendation. So if you think of the ovarian reserve testing, there are three ASs which are important: age, AMH, and AFC. Other investigations are not that reliable. Age is also not said to be reliable alone, but AMH and AFC are said to be alone reliable for the ovarian reserve testing. So keep in mind, friends, that there are three S's which are important: age, AMH, and AFC. And out of these three A's, AMH and AFC are alone reliable for the ovarian reserve testing. Right? Now we come to the ovarian induction. Now we should do ovulation induction in this patient, and we may not do tubal patency because tubal patency is not required, but we have to start treatment immediately. As I told you, lifestyle modification is something which you have to do. 5% weight reduction is going to make a big difference, and you should not give her unrealistic approach. So there is a smart approach. The approach should be smart approach. The approach should be such that it should be measurable, it should be realistic, and it should be achievable. So this is what we always say, that you reduce weight by 5%, you will get results, benefits, and ovulation will start happening. Then we are now talking about the adjuvants. And when we talk about adjuvants, we give adjuvants along with the ovulation induction. So we have thought of giving ovulation induction to this patient, Yasmin, because she is anovulatory. She is not having ovulation. So there is something called as off-label use. And what is off-label use? There are drugs which are used for some other purpose, and they are not used for the ovulation induction in many countries. Like letrozole, you might be not aware of this because now you are young, but during our 10 years back, initially there was letrozole available in the market, then there was a ban on the letrozole, and CC was again, people started using CC, and then the ban was lifted, and again the letrozole is now available for ovulation induction in India. But there are some countries that even their metformin is also off label in many countries. So you should discuss this with the patient, that whenever you are using any drug empirically or off label, there are many evidences and there are many studies, there are many papers which have said that this drug can be used as an off-label drug for a particular situation. And discuss this with the patient, counsel them, tell them about the possible concerns of side effects, and then evidence-based use of off-label medicines is allowed. Therefore, metformin can be used for ovulation induction as an adjuvant, though it is off-label in many countries. Letrozole can be used because it is, though off-label, it is useful. So everything is set for ovulation induction. The first thing we do is exclude pregnancy, start ovulation induction, and discuss about the off-label use. Coming to the adjuvants. Why do we need adjuvants in PCO? Because there is insulin resistance and hyperinsulinemia. We have discussed this. There is androgen excess. We have discussed this. There is obesity. We have discussed this. And there is a classical metabolic syndrome in a patient. So these are the situations where you need adjuvants. And also there is a CC resistant PCOS. And this CC resistance is something where adjuvants work wonders. And when the clomiphene citrate is not working, now CC is replaced by letrozole. So you can say letrozole resistant patients who are not responding to letrozole. I'll come to you. I'll come to this and I'll tell you about this. But try to understand that this is a situation where adjuvants work very well. The list of adjuvants. What are the adjuvants which are available in the market? Metformin is the first. Myoinositol, decanoinositol combination is second. Glucocorticoids, statins, N-acetylcysteine, melatonin, vitamin D, L-methylfolate, and chromium picolinate. All these drugs are, this is a list of drugs which are used for PCO. We have to choose adjuvants in a smart way. It shows your clinical acumen. So you will be known as a good doctor if you know how to use adjuvants in a smart way. ऐसा नहीं है कि सब पेशेंट को सब adjuvants दे दो. That giving adjuvants depends on the situation, depends on the problem patient has, and problem wise, you have to give the solution. So it's a smart approach which you have to understand and try to do. What are the areas of focus? We'll discuss about the adjuvants, we'll discuss the role of adjuvants, we'll discuss how it works, dosage of adjuvants, the place of adjuvants in new guidelines also we'll discuss, and we'll discuss practical use in a day-to-day life. अब सबसे पहले regarding the hero of the adjuvants. Do you know who is the hero of the adjuvants? Adjuvants का hero कौन है? बेशक metformin है. Metformin is the hero of adjuvants as far as PCOS is concerned. For PCOS, the first thing that comes to your mind whenever you discuss about adjuvant is metformin. So metformin is the first thing or the first drug that comes to our mind. And we will start discussing metformin one by one. And we will also discuss the guidelines. First guideline is the ASRM guideline. And then at the end, I'll discuss the ESHRE guidelines. ASRM guideline 2017 is grade A evidence that metformin improves ovulation rate. Grade C, insufficient evidence that it reduces the chance of miscarriage in pregnancy. Cochrane data says that it improves the menstrual frequency, ovulation rate with marginal improvement in live birth rate as compared to placebo. So this is what the ASRM says. Grade A evidence that it improves ovulation rate. Therefore, no question, it is good. It's an insulin sensitizing agent. It is an oral biogonide. It lowers blood glucose level in hyperglycemic type 2 individuals. So in diabetes type 2, we know that metformin is given. There is no effect on glucose level in normal subjects. This is a very important point because the PCO patient is going to ask you this question कि मेरा diabetes का कोई संबंध नहीं है, मेरा शुगर नॉर्मल है, तो मैं metformin कैसे लूं? और मैंने metformin लिया तो मेरा शुगर तो कम नहीं होगा. Then these are the FAQs which you have to answer. For that, you should know the details about this drug. So no effect on glucose level in normal subjects and does not induce hypoglycemia. So whenever patient tells you, तो okay, मुझे diabetes नहीं, तो आप मुझे क्यों दे रहे हो? मेरे चाचा को diabetes है, मेरे मौसी को diabetes है, मेरे मम्मी को diabetes है, उनको वो metformin की गोली खाते हैं, आप मुझे क्यों दे रहे हैं? मेरी sugar level तो normal है, but even if her sugar is normal, you know that you have to give her for ovulation induction, for improvement of the oocyte quality. So you have to tell this that beta, your sugar levels are normal, so you will not land up in hypoglycemia. Don't worry. Mechanism of action. It inhibits hepatic glucose production, improves insulin stimulated peripheral glucose uptake by liver, skeletal muscle, and adipose tissue, reduces absorption of glucose uptake from GIT, lowers serum lipid levels as well. And the bioavailability is 50-60%. It is an oral drug. That is the beauty of this drug. You have to start with 500 milligram per day and increase the dose weekly to 1500 milligram per day. That is usually the maximum dose which is given is 1500 milligram per day. I'll discuss this also in the guidelines. And this you have to do after confirming by doing LFT and KFT. So do LFT, KFT, and then you should do this and increase the dose. There is no evidence of teratogenicity. That is the best part. And that is the reason why metformin is now regularly given in pregnancy and for various reasons, which we'll again discuss later. How long? And I think Madhuri madam is with us at the end of the talk. We can discuss this also because it is said that there are very few studies regarding the long-term use of metformin. So whenever anybody asks you a question, how long you will give metformin? The answer is 3 months. It's okay. You have to give it for 3 months. That is right. But what about long-term metformin use? You can actually give it for long-term period also. And the possible role of long-term metformin is something which is awaited. And since we have an expert like Madhuri madam, she is my guru, she is my mentor, and she will tell us about this, that how long we can give it. More than 3 months. Usually if we give it for more than 3 months, we have to just understand that how long we can give it. It's a category B drug. Therefore, side effects are dose dependent. Maximum side effects are GI side effects: diarrhea, nausea, vomiting, flatulence, asthenia, indigestion, abdominal discomfort, headache. A very rare side effect is lactic acidosis, which is fatal. And almost all patients who develop acidosis are having impaired renal function. And therefore, you should do KFT in this patient so that you know about the possibility of lactic acidosis. I have never seen this situation, but then this is mentioned in books, and you should know that lactic acidosis is a rare side effect which is seen in the impaired KFT patients. The guidelines about ovulation induction agent, they clearly say that the first ovulation induction drug is CC, but now CC is replaced by letrozole. The first line of drug for ovulation induction in PCOS is letrozole. Remember this, it is not clomiphene citrate, now it is letrozole. So letrozole is the preferred drug for ovulation induction. Now the question is, can you use metformin as a alone as a ovulation induction agent? Answer is no. You cannot, you should not use it alone because CC and letrozole are better than metformin. But clomiphene citrate could be combined with metformin rather than persistent use of CC alone in women with PCOS who are CC resistant with unregulated infertility and no other infertility factors to improve ovulation and pregnancy rates. So try to understand this. CC metformin combination is the next step which you can do if the patient is not responding to CC. And whenever I talk about CC, I mean to say letrozole, because this is the term which is terminology which is used, CC resistance, but now CC is replaced by letrozole, so it is a letrozole resistance. So even in letrozole patients who are not responding to letrozole, the next step of treatment is to add metformin. So it is a combination which works. So this is a step which is before HMG, and this is a combination which is worth trying before shifting to more costly gonadotropins. Why? Because it is less expensive and it is more convenient. And these are the studies which have mentioned that in CC resistant cases, metformin and CC combination works wonders. So letrozole metformin combination works wonders. Now comes the algorithm. This is the algorithm which you should try to understand. You give CC to the patient, she will ovulate, she may not ovulate, or she may have problem with endometrium. The problem with endometrium is taken care of by letrozole nowadays. Then you go to the next step, and this level you can call it as 1B. So 1A is letrozole and 1B is adding metformin to the letrozole. And still if there is no pregnancy, then you go to the next level treatment, that is level 2, and level 2 is gonadotropins. Before level 2, that is gonadotropins, you can try metformin combination. That is the best part of metformin, which is a wonder drug. Not only CC and letros, metformin works well with gonadotropins as well, because it is a good cocktail. It blends very well with gonadotropins, and therefore in IVF also, if you give pre-treatment of metformin for 1 month, you will get less large follicles, it will produce less estradiol, you will get fewer cycle cancellation, and you will get good quality of oocytes. Therefore, it is a good drug not only for the simple treatment of time intercourse or IUI, but also for IVF in combination with gonadotropins. And this is what the guidelines regarding IVF say. See, this is a guideline of IVF, 2019 guideline. What it says that adjuvant metformin therapy could be used in agonist protocol for along with FSH hormone for ovarian stimulation to improve clinical pregnancy rate and reduce the risk of OHSS. Another important advantage of metformin you have come to know now, and that is reducing the risk of OHSS. So not only it helps in ovulation, but also helps in improving the fertility outcome by reducing the chances of OHSS as well. And see the dosage. What dosage they have said? Commencement at the start of GnRH agonist treatment. Start with the dose of 1000 to 2550 milligrams. So this guideline has said that maximum daily dose should be from 1000 milligram to 2550 milligram per day. Metformin cessation at the time of pregnancy, unless it is indicated for diabetes, you should stop it during pregnancy. That is what they say. And metformin has got side effects which you should explain to the patients. And not only with agonist protocol, they have said that you can use it for along with antagonist protocol as well to reduce the chances of OHSS and decrease the risk of ovarian stimulation or hyperstimulation. You should not give metformin contraindications in case of renal disease. When the creatinine is more than 1.4, then when there is a cardiac failure, acute or chronic metabolic acidosis, sepsis, liver disease, alcoholism, and you should stop this metformin before IV contrast use and stop it before surgery. These are the contraindications. You should know all these contraindications. What are the advantages? One thing, weight loss. Then second, helps in ovulation induction by benefits on the parameters of metabolic syndrome. Works better in combination with CC than alone as an ovulation induction agent. We have discussed this. reduces free androgen index and testosterone levels. So we have discussed biochemical levels as well. Reduces chances of OHSS by ameliorating expression of VEGF. VEGF is the culprit. VEGF is the kingpin for OHSS. So it reduces the expression of VEGF, therefore helps in reducing the chances of OHSS. It improves clinical pregnancy rate by impact on the hyperandrogenism and insulin resistance, thus improving folliculogenesis. अब जो कुछ भी हमने डिस्कस किया था सब कुछ इसमें आ गया. Hyperandrogenism, insulin resistance, testosterone level, free androgen index levels, VEGF, everything is taken care of by this metformin. So uses, we have discussed this: ovulation induction in CC resistant cases in combination with CC, PCO with type 2 diabetes mellitus, obese PCO for weight loss, and reduces OHSS chances in IVF. To make a difference in someone's life, you don't have to be brilliant, rich, beautiful, or perfect. You just have to care. And if you care, you have a empathetic approach towards your patients, you are definitely going to get your results. Next is the thiazolidinediones. And these are the drugs which are used in the treatment of type 2 diabetes. It decreases insulin resistance at periphery and liver and increases insulin-dependent glucose disposal. Because of this action, it is used in PCOS as well. It is metabolized in liver and half-life is 3 to 7 hours. Rosiglitazone and pioglitazone are the two drugs which are used because they are relatively free of liver toxicity, and still you have to do LFT every 2 monthly. Troglitazone was a drug which is now withdrawn from the market. The rosiglitazone is 4 milligram per day, increased to 8 milligram per day after 8 weeks. Pioglitazone is 15 to 30 milligram per day OD dose, and you have to know of the side effects of this drug, which are almost similar to metformin. GI side effects are there, hepatic effects are there, therefore you should do LFT every 2 monthly. Weight gain is the problem, edema is the problem, congestive heart failure is the problem, and pioglitazone is known to have more chances of bladder cancers as well. So it is contraindicated in heart disease, it is contraindicated in liver failure, it is not to be given during pregnancy and lactation. Unlike metformin, this drug should be stopped before pregnancy or during pregnancy. And also it is known to cause fetal growth retardation. It's a category C drugs. Therefore, you should discontinue it as soon as the pregnancy is established. So that is about the rosiglitazone and pioglitazone. Next comes the inositols. And these inositols are now becoming more and more popular day by day. Inositol is an insulin sensitizer. It acts at the level of ovary. It reduces hyperandrogenism. It regulates the menstrual cycle. It helps in spontaneous ovulation. It improves the ovarian response, and it improves the oocyte competence. So at the level of ovary, it has got a very good action. And therefore, this myoinositol is being used regularly nowadays as the adjuvant. Now, the key question is, what is the role of myoinositol and what is the combination of myoinositol and decanoinositol which should be used in the treatment of PCOS? And guidelines say that is ionositol alone or in combination with other therapies effective for the management of hormonal and clinical PCOS? And features of weight reduction in adolescents and adults with PCOS? The answer says that myoinositol in any form should currently be considered as an experimental therapy. This is what 2018 guidelines have said, but they have encouraged to advise health professional to use this drug. And we have taken this point well, that we should be encouraged to use this drug, and it is a complementary therapy. So you can use inositol as a complementary therapy, and the guidelines, they only say that you should encourage to use this drug more and more commonly because it's a good drug. Why it is a good drug? Because there is emerging data about the metabolic, hormonal, and ovulatory benefits of this drug. It is freely available. It is cheap. It has got limited side effects. Therefore, it warrants consideration for use despite of limited and low quality evidences. So the quality of evidence is low. The references are limited, but it can be used because it is cheap, it is freely available, and the side effects are minimum and less as compared to metformin. So that is the advantage over metformin, and that is the reason why you can use it for the treatment of PCOS as an adjuvant. Decanoinositol is one more drug which has got a peripheral action. It acts at a periphery to reduce the insulin resistance. It improves glucose metabolism, improves lipid profile, reduces carbohydrate metabolic complications, and therefore, if you combine myoinositol with decanoinositol in the ratio of 40:1, it ensures better results and therefore this combination has become very, very popular. 2 to 4 milligram per day is the dosage which is given. Vitamin D. Vitamin D has got beneficial effect on all these factors. Insulin resistant hyperandrogenism, follicular maturation. It is to be given in the dose of 50,000 IU tablet or 60,000 IU sachet per week. Till you achieve a level of 20 nanogram per ml. It can lead to hypercalcemia, and I remember Madhuri Patil madam always says, sorry, that be careful while using these vitamins. There can be hypervitaminosis, and that is exactly what happened during COVID also. People were like taking so many vitamins and minerals and multivitamins. This itself can lead to problems like hypercalcemia, can lead to headache, nausea, vomiting, dizziness, loss of appetite, and dry mouth. 3 months of vitamin D3, 400 IU per day, and calcium 1000 milligram per day is the best dose which you can give to the patient. It has got a positive effect on follicular maturation and also menstrual disorders. L-methyl folate. It reduces homocysteine levels, and therefore 1 to 5 milligram per day for 3 months of folic acid in combination with vitamin D can be used to reduce follicular levels of homocysteine and thus improves fertilization and clinical pregnancy rates. So L-methylfolate is one more drug which can be used. Then comes the antioxidants, and the first drug is N-acetylcysteine. This N-acetylcysteine is used not only for increasing the glucose utility, decreasing the cholesterol level, homocysteine level, and increasing HDL levels. It has got an anti-apoptotic action because it's an antioxidant, and also has got effects on the cervical secretion. It aids in healthy cervical secretion. It helps in the entry of sperms inside, and the cervical mucus, which is hostile many times, which prevents the entry of sperms or semen inside, can be taken care of by N-acetylcysteine. And it is also good in CC-resistant PCOS. The dose is 600 milligram BD for 4 to 6 weeks. So this is N-acetylcysteine is one drug which is good for cervical secretions also, apart from the follicular action. Melatonin also can be used because it's an antioxidant. It reduces oxidative stress and improves the follicular growth. L-carnitine, one more drug which can be used for improving the insulin resistance and improving the lipid profile. 3 grams per day for 8 to 12 weeks is the dose of L-carnitine. And then omega-3 fatty acids, 4 gram per day for 8 weeks, reduces insulin resistance and total cholesterol levels. Soya and phytoestrogens are also very good, and therefore should be given 18 milligram per day for 3 months, which reduces oxidative lipid damage and prevents cardiovascular and metabolic disorders in PCOS. Coenzyme Q10, this is the adjuvant which improves the oocyte quality. And this is the drug which is becoming very popular, and almost all the combinations of antioxidants which are used for improving the oocyte quality contains coenzyme Q10, not only used for female infertility, but also used very popularly in male infertility with oligospermia patients. So coenzyme Q10 is used in both male as well as female for improving the sperm quality and the oocyte quality. Zinc, 50 milligram per day for 2 to 3 months, can be used for reducing cholesterol level and also beneficial effect on the metabolic risk factors in PCOS. Chromium picolinate, 200 to 1000 microgram for 4 to 6 months, can be used for improving insulin resistance, body weight, and helps in ovulation. Selenium is also one drug which can be tried, and the multiple micronutrients like vitamins, L-arginine, glutathione, minerals like iron, zinc, magnesium can be used for reducing the ROS levels. Corticosteroids. This needs special discussion and special attention. Whenever the patient with PCOS has got high adrenal androgens, high DHEAS levels, these adrenal androgen levels can be reduced by corticosteroids and has got an indirect action on improving the ovarian response to gonadotropins. So indirectly, it helps in ovulation. It improves the ovarian response to gonadotropins, but it has got more impact, major impact on the adrenal androgen levels. And the dosage is dexamethasone 0.25 to 0.5 milligram per day from the mid-luteal phase of the previous cycle, or you can try it from the ovarian stimulation in the follicular phase of the ovarian stimulation. Prednisolone can be given 5 milligram per day or dexam 2 milligram per day from day 5 to day 14 of ovulation. These are the drugs which are used, steroids which are used, and we use steroids quite often in PCOS patient, especially if the patient has got adrenal androgen levels high, and also to improve the oocyte quality in IVF as well. A very interesting thing, and since last 2 years, ICOG is giving me this treatment, this lecture on OC, on the pre-treatment in IVF cycles, and therefore this is the topic which is close to my heart. We will discuss this with Madhuri madam after the my talk is over, regarding the role of OC pills pre-treatment. It is said that OC pills, they reduce the LH levels. And if the high LH levels are there in PCOS, we all know that especially in lenient PCO, LH levels are high. This will help in reducing the LH levels. It also reduces the androgen levels, improves the folliculogenesis, and therefore OC pills can be used for pre-treatment. However, it results in more days of gonadotropin therapy and higher doses of gonadotropins. Why you require more doses of gonadotropins? Because there is a suppression of the HPO axis by the OCPs. And because of the suppression of HPO axis, you require higher doses of gonadotropins, and that is one point. And now very interesting thing is about the 2019 guidelines for ovarian stimulation. They have discussed 4 pre-treatment therapies: estrogens, progesterones, OCPs, and antagonists. And they have said that they are of no use. They should be used only for scheduling purpose, otherwise they are of no use. And this is the strong recommendation which says that OC pill pre-treatment for 12 to 28 days before cycle is not recommended in the GnRH antagonist protocol because of the reduced efficacy, and therefore they strongly said that please do not give OC pills for antagonist protocol. So now you have to decide about the reducing LH levels, cycle regularization, and also the reduced efficacy because of the OC pills, which is the recommendation given by 2019 guidelines. So ultimately, you have to take the decision, and this we'll discuss at the end of my talk. Statins, simvastatins and atorvastatin. These are the drugs which are used for improving the lipid profile. And this is the slide which is given to me by Madhuri madam. And I think you should take a screenshot of this slide because it's a busy slide, but it gives you idea about whatever we have discussed till now. The applications of adjuvants in PCOS. This is the slide. Thanks to Madhuri madam. Madhuri madam has given this slide to me, and this is the slide which gives you at a glance idea about all the drugs which are used for the as adjuvants in PCOS. Dexamethasone, metformin, myristoyl, vitamin D, N-acetylcysteine, melatonin, chromium picolinate, antioxidants, micronutrients, and L-methylfolate. Coenzyme Q10, vitamin D3, dopamine agonist, and aspirin. Now, add-on is something which will give you success. Add-on and you will succeed. But the smart use of adjuvants is the key to success. Therefore, what is the take-home message? Again, a message not by me, but by our guru, Madhuri madam, which is a very interesting message. This message says that off-label prescription of adjuvants for the treatment of female infertility is widespread. Many supplements are inexpensive and generally well tolerated. In the field of reproductive medicine, it is common for an innovative practice to become widely used before demonstration of its efficacy, because हमको कुछ ना कुछ तो करना है पेशेंट के लिए. So we try to, reproductive medicine ये ऐसा vulnerable field है जिसमें you tend to use many drugs because you are frustrated. You want results and patients also want results. So this is the field where you have to have more, clinical acumen and a proper and smart use of their adjuvants. And patients with infertility are particularly vulnerable to trying new treatments in the hopes of conception. And because of this hope of conception, they try new treatment, and good medical practice dictates that the physicians keep the best interest of their patients in mind and counsel patients appropriately about the best evidence available and potential adverse effects of the treatments which are prescribed. So use adjuvants to add color to life, to add success rate to your patients. Thank you very much. And my special thanks to Madhuri Patil madam, special thanks to Dr. Lakshmi Shikande for giving me this wonderful opportunity. Thank you, Madhuri madam. Thank you.
Thank you for that excellent lecture, Chaitanya. And there was one question from the previous lecture. The oral dose of oral DHEA, it is 25 milligram 3 times in a day. and it has to be given for a minimum period of 3 months before we start the ovulation. So the next question to you is, can we continue myoinositol, DCI, methylfolate, dexamethasone, and antioxidants during stimulation?
Yes, of course, we can continue.
Basically, dexamethasone is given from day 2 to 11 of the cycle in the dose of 2.5 to 0.5 milligrams. Basically, we use more of 0.5 milligrams. Antioxidants are basically given only in poor responders and in hyper responders, because we know that it is associated with mitochondrial dysfunction, and antioxidants improve. Out of the antioxidants, CoQ is supposed to be the best adjuvant given in poor responders as well as in women with PCOS. Myoinositol, I don't agree because there's still no evidence, though there are many using it. And
Yes.
methylfolate, anyway, we are giving.
Even the guidelines say that myoinositol is still an experimental therapy. And madam, I just wanted to ask you about this OC pill pre-treatment.
So basically what, especially in IVF, it's best to use estrogen or progesterone for about 8 to 10 days. So I use basically a norethistérone because of the progesterone. Norethistérone is supposed to be the best because it has been seen that on day 2, when you do the progesterone levels, it's not raised. When you're using medroxyprogesterone, many a times on day 2, your progesterone levels could be at a higher, on the higher side. Or you could also use estradiol valerate, 2 milligram twice a day from day 16 to day 25. OCP should, they said that it reduces the clinical pregnancy rate as well as the live birth rate. But the newer studies which have come have said that if you have a washout period of more than 5 days, then there is no difference in the clinical pregnancy rates and as well as the live birth rates. So one thing to remember is the high LH in PCOS is basically tonic, and it does not really affect the results in whatever gonadotropins you're giving. So we should not look at the LH levels when we are doing, we are stimulating the patient, because they are not, it's not the active form of LH which is present. It's basically a tonic elevation of the non-active form of LH, and therefore it really does not make a difference. But basically, just to have a uniform cohort of follicles growing, we use the pre-treatment, and we could use any of them. Once we get the depot preparation of GnRH antagonist, it would be really great, wherein we give one single dose on day 25, because now it's in the 3rd stage of trial. And then its effect will last till you give your trigger.
Right. So it will save a lot of injections, and it is going to be a great help. Right.
So they're asking metformin and myoinositol be continued once pregnancy is confirmed. Again, that is controversial.
Metformin, of course, no. Myoinositol, no. We should stop. As far as metformin is concerned, that is what the latest guidelines have said, that metformin should be continued if there is an indication of metformin. But if you are using it for ovulation induction or as an adjuvant, then you should stop it.
Yeah. How to decide the starting dose of Gonal-f for HMG? Basically, it is decided on the AMH, antral follicular count, and this has to, and the age of the patient, and this has to be amended for the BMI. So if the BMI is larger, you require a larger dose to be started, and if the BMI is less, you require a smaller dose. So if you are giving it in a patient who's younger than 32 or 35 years, then you can start with a smaller dose. If it's a patient who's more than 35 years, you start with a larger dose. If the BMI is less, again, you start with a smaller. If the BMI is more, you start with a larger. So in PCOS, basically, if the patient is young and BMI is more, you can start with 150. Or if she has not responded to 150 earlier in her cycles, then you can start with 225. But if she is a thin PCOS, then it's best to start with 100 international units. All this is for ART cycle. But if you consider a non-ART cycle, it's best to start 37.5 in a low BMI and 50 IU in a high BMI patient. The E2 cutoff on day 2 has to be 50 itself. It cannot be more than that. And for progesterone, it has to be 1. Initially, it was thought to be 1.5, but now it is taken as 1 nanogram per ml. There are some which also take as 0.8, but normally what we take is 1 nanogram and 50 picograms for the estradiol levels. you are anyway going to stop your estradiol on day 25, and there's always a washout period of about 5 to 8 days before the patient gets her cycle. And therefore, therefore, basically, that estradiol is not going to result in raised estradiol levels on day 2 of the cycle. There's no LH cutoff which is there. So basically, it really does not make a difference. So as long as you start in an ART cycle, as long as you start your antagonist in proper time, you will not have a high LH level, which is active basically. And therefore, you will not have rise in the late progesterone level, which can affect the implantation. So it's best that we do a E2 level on day 4 of your stimulation. And depending upon that, you can start your antagonist. So if you're using a fixed protocol that is on day 6, then, and if your E2 is already 300 to 350 on day 4, then it's best to start on day 5. And yeah, when you're using a flexible, I don't think we should wait till 14 millimeters, because in a patient of PCOS, basically what happens is you have multiple follicles that are growing, and therefore your E2 is much higher as compared to the follicular diameter. And therefore probably you require to start it earlier. And the day you will start will basically depend upon your scan on day 4 and 6, as well as on the E2 levels on day 4. Any other questions?
I hope you all enjoyed this session.
We'll wait for 2-3 minutes because it's send late questions many times. Any more questions?
Yeah. Some words of appreciation. Thank you. Thank you, Rudri.